So look, they're on there. Hopefully so my plan for Thursday is that I will have the neck done and have opened up the chest cavities on 2 of the cadavers. Because I want to do a couple of different things on them, I think. One is I want to be able to kind of leave everything intact and make it somewhat relationship-wise, be able to see that, and then the other one take heart and probably left lung out so that we're able to see the relationship with mediastinum and vena cava coming in on that side. So at least that's my plan right now. Have to see what happens tomorrow afternoon, how it goes. The other question though is what to do about third exam. So when I emailed the question out last week, I got one response. So do you guys think? So here's my thinking on it. If I don't do third exam on head and neck, and I can do that, we could do it Monday because we could then look at head and neck stuff on Thursday, which is kind of what I thought I kind of gathered from everybody's take was that if I could see it before I took the written test, then that way it would make more sense in taking the written test. And then that way, so from that point of view, I could look at doing a test on Monday after we saw head and neck stuff this Thursday. If I put it off much to Thursday so that you had even the next Tuesday, if you guys were free to go into the lab and look at that with me and go over it again, well, that's fine, but then that puts the last test kind of barreling up right on top of the other tests. So I really don't, certainly it's not up to me. It really isn't up to me. It's up to you guys, how you would rather do it. The other option is to just have a bit longer exam on the 9th, that is the 9th, right? And you guys still want the lab exam and the lecture exam all on the same day? Okay. It would just make that exam a little bit longer because I'd have to put the appropriate number of head and neck questions on that exam, plus the internal organ system stuff on that exam, plus some review stuff going back to the upper and lower extremities. So it's up to you. Again, I got one response, so I'm not asking for you guys to take a poll right now and do it, but just somewhere between now and Thursday, so I know kind of how I can plan my, not dissection, that's pretty much set, but how I can plan going forward in terms of time for you in class as well as setting up the exams. Okay? Are there any questions on that? Okay, lab exam was much better than last time. The average on it was 86%. So, whatever it was, more time in the lab. Can't think it was easier, but maybe it was. So. But anyway, so that's kind of where we are. Hope you guys did okay with the snowstorm. I sat there and watched my lights flicker and the computer go on and off and on and on. So, the joys of living at 6,500 feet out in the wind-blown prairie. I think this storm was actually worse than the blizzard 2 weeks ago. So, for me anyway. So, Okay, anything? Any questions? Comments? Went sledding over the weekend? No? Okay. You know, I was actually, so this has nothing to do with class. I was sitting there, yesterday I barreled through the drifts and got out because I had to get out, because I had to sign my tax stuff and get it paid, you know. Wait till the last minute. But I was looking at some of the hills and going, why aren't there kids out sledding on this? Because when I was a kid, it's all I ever did in the snow was sled. So, but I didn't see any kids out sledding, so. Okay, so this is kind of where I stopped. So we ran a little long the other day, and it was because we had the discussion, and I really wanted to get through at least the arterial supply, the coronary arterial supply to the heart. So I got a little bit of stuff left to do in the heart, and then kind of the abdomen, start in the abdomen. Okay. So the thing I want you to see on this image isn't so much the idea of the blood flow. That's just blood coming through up through the superior vena cava, that venous blood coming out. That's all the blood supply from the head and neck and both upper extremities. So you'd have a brachiocephalic vein on both sides coming in and ultimately combining to form this superior vena cava. That's all the upper extremities, head and neck. Inferior vena cava coming up, which is really a combination, and we'll talk a little bit about it as we go through the abdomen, but it's really everything from below. So it's including all the blood supply from our lower extremities, from our kind of the musculoskeletal side of the trunk, but then it also is mixed now with the hepatic vein, which is the portal system that's carrying blood through the intestines. So that's a combination of blood coming into the inferior vena cava. And one of the things I want to be able to show you is how this is really kind of a short stalk, and it comes out of and comes through that lateral wall of the mediastinum to just from the liver almost directly into this. So it's kind of interesting of how that's organized. The other thing that we ended with on the other day was that the venous drainage from the heart was coming in through the coronary sinus. So here's the coronary sinus. So you have these three pieces that are bringing that venous blood back into the right atrium. Now this area right here, fossa ovale or oval fossa, does anybody know what that is? Foramen ovale, fossa ovale? Okay, so when we look at fetal circulation, and without going into how the heart's formed, because it's a lot of kind of this twisting, it starts out as a single tube, then folds on itself and stuff. But basically, fossa ovale is an opening in the interatrial septum, so that coming in really through the vena cava is the placental blood. So it's really the oxygenated blood that's coming into the system at that time. And as that oxygenated blood comes into here, since there's really no reason to have blood going into the lungs for exchange of gases, because the placenta doesn't need that at that point, and that's all taking place in the placenta. The fetus doesn't need it, the placenta does it. But ultimately, that blood comes in and it shunts directly from the right atrium into the left atrium. And from the left atrium then goes into the left ventricle and then pumps out. Now, there's another shunt that's not shown on this, that ultimately, that any blood that does get into the right atrium and then is pumped towards the blood, there's something called ductus arteriosus that then takes that right ventricular blood and puts it out into the aorta as well. So there are two shunts in there that allow for that fetal circulation to then be pushed on really past the pulmonary circulation and the pulmonary piece of that. So fossa ovala is just really kind of a thin area of that interatrial septum where that particular opening has closed once the baby's born. If it doesn't close, it can actually stay open or patent, and therefore what happens, there is the potential that this deoxygenated blood can actually, instead of going through the system it needs to, can actually get into the left side of the heart and mix with the oxygenated blood, and therefore there's a decreasing amount of that oxygen carrying capacity on the other side. Now we have had a couple hearts that have had patent foramens, and they've been in different orientations or relationships. What you see here is there's kind of this rim, and this rim almost forms a flap, and if that flap doesn't seal, that's that patent situation, but usually that flap still holds closed like that. So when there's pressure in that right atrium, instead of it just being wide open, it helps to close it, or at least to keep it relatively sealed, even though it's not completely closed. And so there's very little risk of a lot of blood going into the left side. If it's wide open, then surgically it has to be closed off so that that doesn't take place. Okay? Now, the thing I want, and what we want to look at, there are a lot of terms over here, crista terminalis. We're not going to worry about that. What I really want you to look at is the relationship of the wall of the atrium, and if we looked at the wall of the left atrium, it would look somewhat similar. But you notice out here, this is the outer wall, and this outer wall has all these ropes of muscle. These are all just cardiac muscle. They're called pectinate muscles, but they're really just cardiac muscle. And then you look at the inner wall, or this interatrial septum, and it's relatively smooth. And the idea of that is, in terms of the vascular, in terms of pumping the blood, these ropes of pectinate muscles allow for a great deal of contractility pushing against that interatrial septum. And the idea is that interatrial septum then ultimately is going to open towards the atrioventricular valve. If it contracted the other way, if it contracted completely from all sides, then as this orifice down here for the atrioventricular valve, it would kind of push it, help to close it, and limit how much blood could actually go into that valve or through that valve. Okay? Now, when we look at the wall of the ventricle, we see something very, very similar to that. In other words, we're looking at the myocardium, and then when we look on the outer part of that myocardium, there's also this kind of rope-like look of the wall, which is now no longer called pectinate muscles, but it's called trabeculae carneae. And again, it's a way by which the contraction can be most efficient towards pushing blood towards the openings. In the case of the right ventricle, that means it's going to push it towards the pulmonary valve, and as it pushes towards that, then in addition to the contractility of that, there's also contraction of these small muscles, or these small domes of muscle called papillary muscles, that contract just in advance of the ventricular wall contraction. And that small amount of contraction then pulls on these chordae tendineae, which stabilizes the valve so that it doesn't prolapse back into the atria. If those valves contract, or if those little muscles contracted after the ventricular wall contraction started, there's a greater risk that those valves would prolapse and or let a lot of or let some of that ventricular blood push back into the atria. By doing it, by having that little bit of contraction just in advance, it's stabilizing that connective tissue wing. And all those valves are connective tissue. They're not cardiac muscle in any way. Okay? Now, we talked the other day, and the reason I wanted to look at those images of circulation of the heart is because when we look at the conductivity of the heart, in terms of how these muscles contract and why they contract and why they are insulated from each other, we have a sinoatrial node up here close to kind of where the superior vena cava comes into this right atrium. And this is kind of the area that begins a wave of depolarization across the atria. Now, when we look at that specific to the atrial walls, there isn't a conductive system within there. In other words, there are not neurons in there or modified cardiac muscles in there that are going to direct or provide a pathway or a direction by which the contractility takes place. It really is just a wave that streams from here towards the wall or this interatrial septum. And again, as it spreads over here, it's doing something very similar, that it's spreading across the entire wall. So when we started, we looked a little bit about the differences between skeletal muscle and cardiac muscle. We talked about them both being striated muscles, but there was some variation in that. And just taking advantage of the fact that there's a lot of gap junctions and allows for transfer of that electrical signal and the transfer of calcium signals for that contractility to take place, then ultimately the wave of contraction over the atrial side really is consistent around the entire wall. But what it ultimately does is it hits kind of this atrioventricular limit, and we'll look at that in a minute, but at that point there is the atrioventricular node. So as that wave of electricity, of that contractility goes across all the atrial wall, it ultimately then comes down and is directed towards and collects at the atrioventricular node. And this is the only way from this atrioventricular node through this bundle to get through the connective tissue separation that occurs between the atria and the ventricles. Okay? If there wasn't this connective tissue kind of insulator between them, then this wave of depolarization would ultimately, or could ultimately then come in this direction and cause the ventricle to contract at the same time the atria contracts. That's not an efficient method. So all that atrial depolarization ultimately collects at the atrioventricular node, and then through this bundle, then it gets into the interventricular septum. Okay? And then from the interventricular septum, then there are bundle branches that travel and circle around, come to the apex of the heart, circle around into the wall, and branches that go into the papillary muscles, and the same thing goes to the left side. Okay? Now, this picture down here is really just that idea of that fibrous or that connective tissue skeleton, if you will, that's really separating the atrial side of heart muscle from the ventricular side. And this connective tissue band is also forming kind of the outside ring for the attachment of each one of the valves, whether it's the atrioventricular valves, the pulmonary, or the aortic valve. Okay? So ultimately, these are the pieces that are really insulating the atrial depolarization, or that atrial cardiac muscle, from the ventricular cardiac muscle. If you looked at them histologically, they don't look any different. Ventricular muscle and atrial muscle, from a cardiac point of view, from a just a small segment of that, doesn't look any different. They still are branched little bitty muscle fibers. Now, what you want, though, what you notice here is now, and this is kind of the simple view of the cardiac cycle, is that here what we're looking at is here we have our EKG or ECG. Here's our P wave, QRS complex, and then a T wave, and then we repeat that. So when we look at this, here's our atrial contraction. So here's ventricular pressure, here's atrial filling, and then contraction. So now we're pushing it into there. Here we're looking at, and this is the sounds, so here's systole, where we get contraction to force that blood out. Diastole is that atrial filling and ventricular relaxation. And then here again we have the complex, the QRS complex, that is the ventricular contraction. What we can't see in the lab, well, sort of we can, but what you notice here when you look at, forget about what it's saying about the valves, if you look at this and you look at the kind of the orientation of those cardiac muscle fibers, there's, instead of being very linear like muscle, like we see the skeletal muscle fibers, there's kind of this wrapping to them. There's a bunch of kind of concentric rings of these that have sort of this interlacing and wrapped kind of thing, which means kind of the easiest way to think about it is, how do we make that contraction most efficient to get rid of the most amount of blood with the least amount of effort? And kind of think of that in terms of how those fibers are interlaced and wrapping. Kind of think about it as kind of just wringing out a dish rag. As you're just kind of, because they're not contracting this direction, they're contracting like this. And by doing that, they're making sure that that entire wall is contracting together and pushing towards that interventricular septum and pushing up against the valves that are hopefully are not letting blood leak back into the atria. But now, how do we get the heart to work? Heart works on its own. That sinoatrial node has its own rhythm by which it wants to contract. Now, we can modify that, and we do modify that depending upon our need. We need more oxygenated blood. Let's get the contraction to beat a little bit more. Let's get more return back. Let the atria fill greater. But the end product of that is really looking from a heart point of view at the relationship between a balance of sympathetic and parasympathetic input to the heart. If we want the heart to slow down, we bias it towards parasympathetic. If we want the heart to speed up or have more forceful contraction, we bias it towards the sympathetic nervous system. Now, when we talked about head and neck a little bit, we talked about the vagus nerve and its really, should I just have that on kind of a tether?
That'd be great.
But the idea is that when we talked about the cranial nerve, when we talk about cranial nerve 10, that's our parasympathetic control to the thorax, all of the thorax. So whether it's the parasympathetic innervation to the heart, whether it's parasympathetic innervation to the lungs, that parasympathetic innervation is all coming from the vagus nerve. But in the neck, the vagus nerve was particular for just voluntary types of activity. In other words, we talked about swallowing. how we coordinate thyroid cartilage and all of the other little cartilages, as well as the super and infrahyoid muscles, to shape and position the thyroid cartilage and therefore open or close that laryngeal pharynx, or whether we were going to swallow or we were going to speak. That's all the skeletal muscle side of the vagus nerve. But as that vagus nerve travels through between the carotid and the internal jugular vein, it ultimately descends down into the thoracic cavity. And then it's going to continue on past the thoracic cavity because it has to get into the abdominal cavity. But at the thoracic cavity level, we have vagus branches coming down. And so if we follow this guy right here, it's coming down, and it ultimately is going to have branches that then are going to go into the heart. But it also has a branch, and we're looking specifically to the left side right now, a branch that wraps around the aortic arch and then heads back up into the neck. That's still the somatic side of the vagus nerve. So the vagus nerve is coming down, and then it has what's referred to as the recurrent laryngeal nerve, which then goes back up into the neck and is part of that somatic innervation to muscles of the pharynx and larynx. There's also a right recurrent laryngeal nerve, which isn't shown on this, but it wraps around the brachiocephalic trunk. So this one is wrapping relatively low, where the recurrent on the right side is wrapping relatively high. Okay? Hopefully I can get one of the dissections to be able to show this. Now, think about the position, especially of that left recurrent laryngeal nerve, and its position specific to the arch of the aorta. Now we're going to go in and we're going to do cardiac surgery. Okay? That recurrent laryngeal nerve, as it wraps around the arch of the aorta, is really in a position where it is at risk of damage during cardiac surgery. We're manipulating the aortic arch, trying to open it up to put coronary artery bypass grafts into it, those kinds of things. Ultimately, that nerve is at great risk for being damaged during that surgery. Again, since it's somatic back up into the neck, what do you think that damage would end up resulting in? Not neck movement, but swallowing. Hoarseness. So think about the idea that, remember, this nerve is really that going to innervate skeletal muscles. And we didn't really get into the different areas of the pharynx and the laryngeal cartilages and the vocal cords and all of that. But the recurrent laryngeal nerve ultimately forms something called and this you don't need to know, inferior laryngeal plexus. And so it's really involved in how those smaller cartilages work to kind of tighten and open up the vocal cords. And in doing that, if it's damaged here, it goes back up, then it can influence swallowing, but it has a big impact on quality of speech. Not in the phonation, not in the formation of the words, but in how much force it's taking to produce the words. Okay? So that on the left side it's pretty critical. Again, the right side is occurring back up here around the subclavian or around the brachiocephalic trunk. It is less at risk during those surgeries. Okay? That's the parasympathetic side of this, is what's left going into the heart. Now, when we look at it from the other side, we've got a sympathetic piece. Okay, we've got a sympathetic piece as well. And that sympathetic piece is the piece that's giving us the signals or the stimulation to the heart that wants to speed the heart rate up, that wants to increase the force of contraction. So when we have a need for greater blood flow, whether it's for greater pulmonary circulation, whether it's for greater systemic need, for exercise or whatever, then we ramp that up. Well, what you notice here is this whole plexus of nerves that are wrapping around the aorta. So remember, sympathetic is arising from the thoracic cord. So from the thoracic cord, you have branches of sympathetic nerves that are leaving there, and for them to get back up into the neck, they form a plexus that wraps around the esophagus, around the aorta, and then continues on up around the carotid artery to carry those sympathetic fibers back up into the neck for whatever we need specific to sympathetic innervation to the face. Okay? Primarily that's salivation and sweating of the face. But ultimately, that sympathetic plexus is wrapping around the esophagus, the aorta, and accessing the heart. And again, that innervation is specific to influencing primarily that sinoatrial node and the atrioventricular node, although it has more direct access to coronary arteries as well. But they just don't go directly into the heart and influence the myocardium wherever they see fit. It's really a system that's run through that conductive system. The influence of either parasympathetic or sympathetic influences a conductive system, not just generally influencing heart contractility. Okay? So when you look at this image, not so much the lymphatic side on that side, but you look at this image on this side, and here you see these sympathetic chain ganglia that are associated with the thoracic spine. Here you can see how they wrap. Here the green is the vagus. It's just a way to designate them on this image. But here the green is the vagus, and then the yellow are the sympathetic sides of that. And then what you see, these blue, purple kinds of things, is really an intermixing of those two sets of nerves. Because when we look at how those particular, the balance between those two sides of the autonomic nervous system, they use the same nerve bundles. And the general term is splanchnic nerves. And we're not going to worry about those. I'm going to try to show you some of the network of nerves, but ultimately, I don't even know them. So I know the femoral nerve, I know the obturator nerve, I don't know splanchnic nerves. But the idea is that there's this huge intermixing of parasympathetic and sympathetic fibers that are traveling in these networks to influence the esophagus or anything that has smooth or cardiac muscle. Okay? Now, when you look at this level, here we're going through the diaphragm, and here we're bringing parasympathetic information down through the diaphragm into the abdominal cavity. So this is the shaded area here is really the hiatus within the diaphragm to allow for esophagus to come through, the great vessels to travel through there, as well as the nerve supplies. Okay? Okay? So here's the idea of that patent foramen ovale. Okay? When this intraatrial septum right here is open, and this is one of the last things that closes, specific to fetal circulation to neonatal circulation. And it takes a couple days for that to occur. It's not like they're born and slap, it closes. So the hormones that are released, the change in pressures that are present because of now pulmonary circulation is necessary, those kinds of things ultimately, again, it's more of a flap. that can seal closed, and then once it's opposed to each other, then they basically fuse together. But they don't have to. But the idea is that now we have this exchange of deoxygenated and oxygenated blood. This is something that doesn't occur very frequently. It does occur, but it closes early in fetal life. So it should be closed at birth. The other place that circulation, and it's not shown on this, but here, what you have here, what's depicted here, is the pulmonary trunk going off to the left and to the right side. At the top of the pulmonary trunk, there is a blood vessel or a shunt up here called ductus arteriosus. And that shunt ultimately does the same thing as foramen ovale. At the time of birth and the need for pulmonary circulation, the hormones released in that ultimately get this thing to kind of scar closed. And it just becomes known as something called ligamentum arteriosum. And it basically is this ligament that's anchoring the pulmonary trunk to the underside or the curvature of the aortic arch. Okay? So those two are pieces that are more commonly left open or patent after birth, and they may or may not play a role in kind of downstream health issues. Again, if it's enough, if foramen ovale is left open enough, it can result in kind of a poor quality of oxygenated blood going to the system. One thing that they're seeing now, specific to patent foramen ovale, is people that have them and have never had any sort of energy losses due to that because of loss of oxygenated blood, is that one of the things that it does is it produces turbulence. And those bubbles associated with that have been correlated with people that develop migraine headaches later in life. So there are ways that they can go in and kind of give the hormones necessarily get it closed, or they may, depending upon the severity of the migraines and the consistency of them, they may actually go in and surgically close that. Okay? But it's that blood vessels that are irritated by air bubbles that are causing the headache. Yes?
What did you say ligamentum, it turns into ligamentum?
Arteriosum. So in there was a picture. So let's go back to way back. I saw it somewhere. Where was it? Thought I saw it somewhere. I don't see it now. But anyway, when we see it in the heart, if I take it out carefully, usually it's like, okay, hurry up, hurry up, hurry up. Basically, it's just connective tissue that's spanning kind of right here at the bifurcation of the pulmonary trunk up to the underside of the curvature of the aortic arch. It's ductus arteriosum. So think about that from the point of view of, here you have placental blood coming in here. We want it to go into the pulmonary, we want it to go past the pulmonary circulation so we get to the left side. But that doesn't mean that blood doesn't come down into the right ventricle. So every time the right ventricle contracts, then it's going to force blood out the pulmonary circulation. It's going to get into here, and again, the lungs aren't ready for that blood to come there and exchange oxygen. So the other shunt, anything that doesn't go this direction, that gets into here, has another route to bypass that pulmonary circulation, can go on into the systemic side. Again, once birth takes place and there are changes in pressures, the lungs start to expand. The hormones released because of that change in pressure ultimately cause both of those things to seal closed. Hopefully. Now, so what I wanted to point out was not so much up here, but this again is kind of referred to the position of the heart, the great vessel specific to the mediastinum. So remember, the mediastinum is just this connective tissue compartmentalization in the midline that is separating the heart, great vessels, and thymus gland early on from the pulmonary cavities which lie on either side of that. Okay? So heart positioned here in the middle part of the inferior mediastinum. This goes into the superior part, and then in the posterior part of the inferior mediastinum, and then down into the abdomen. Okay? Now, what does that have to do with where the heart lies? Okay? So these are the landmarks of understanding heart and where you would listen to for specific heart sounds if you thought something was amiss. So here again, here's our margin of our ribs. The light blue line is the pleural cavity, and it kind of overlaps, so the lungs are kind of anterior, push anterior to the heart. And now the heart lying within the mediastinum is kind of obscured back there. But then these become the intercostal spaces. And those intercostal spaces are important because that's where we listen for specific heart sounds or valve sounds. And this is just an image that's comparing male to female of the position of the actual valve to where you're going to see them. So here's our aortic valve, clear up here. You're going to hear it best. Why wouldn't you hear it best right here? Right over the valve.
Muscle.
Pardon?
The muscles are covered there.
Muscles, and what else is over there? The sternum. So it's lying directly behind the sternum. So you come off to the side of the sternum in intercostal space 2, then you can, that's the best place to hear the aortic valve. You come to the intercostal space on the other side for the pulmonary valve. Okay? Tricuspid valve, which is lying way down in here, again, behind the muscles and the sternum, that you can now, over here, now you can hear it over here, and again, over these two, so the mitral valve and the tricuspid valve in this intercostal space of 5. Okay? So below rib 5. But more lateral. So tricuspid is closer to the sternum, mitral valve is closer to the breast. Okay?
And how is it different in like males and females?
Nothing, but I mean the positioning is relatively the same. But when you think about it, you're really looking at kind of the position of the areola as opposed to kind of being underneath, a little bit underneath the breast, more inferior on the curvature of the breast than just next to the areola in the male. Okay? Why? Because if you were clear up here, you're still having all this fat tissue that you're having to listen to that sound through all of that tissue. So the whole idea is try to minimize what's lying between what you're trying to listen to. Okay? Okay. So, are there any questions on that? Okay. Okay. So when you look at, so now what we're going to do is we're going to drop below the diaphragm and visit the abdomen for a while. So this image I think this image is pretty telling in terms of how you look at the position of the diaphragm in its relaxed state being up in this region, so up behind the sternum and then coming down, and this central tendon as it comes down actually comes, this isn't really telling, but actually comes down and really is interdigitating with the highest, most fibers of psoas major. So it's coming all the way down to the lower thoracic part of the spine and to the upper lumbar region. Okay? When we look at the designation of the different spaces in the abdominal pelvic area, is we're really calling the abdomen from the diaphragm down to the kind of this imaginary circle that is lined or limited by the iliac crest. So the abdomen's kind of right down to here. Then there's this kind of this area of no man's land, which is called the false pelvis, which is from the pelvic brim, which is kind of the pectineal line, sort of that inside lining of the pelvic bones here, and between here and here, this false pelvis still contains abdominal structures. Then we get to the true pelvis, which lies below this pelvic brim, which is kind of right at the level of the acetabulum, down to the pelvic floor, which is just the somatic muscles of the perineum. Okay? And that's really where the reproductive organs are located. Now, the abdomen, when we look at the abdomen, so this is something that we didn't talk about when we talked about the trunk muscles. These muscles really become sort of a component of trunk movement. But when we look at them, kind of the best place to look at kind of this orientation is out here laterally. It doesn't work here on the front, and it doesn't work as these muscles come all the way to the back. But if we're out here somewhat anterolaterally, then we have the skin, we have our subcutaneous tissue, and then we have this deep membranous layer. It's called scarpus fascia. But then we have a layer of these three layered muscles: external abdominal oblique, internal abdominal oblique, and transverse abdominis. And one thing I'm trying to, it's hard for me to say fibularis instead of peroneal. It's hard for me to leave abdominal out of the oblique muscles. But in external, internal, transverse abdominis, 3 layers of muscles. And those 3 layers of muscles, remember when we talked early on about muscle histology, that there was a connective tissue covering of all muscles, that epimysium, that epimysial layer specific to compartmentalizing each muscle. Well, ultimately, each one of these muscles has an outer and an inner epimysium. So green, green, orange, orange, blue, blue. Why is that important? Because when we look at how those epimysial layers are used and formed as we come anteriorly, the fusion of those 6 layers of connective tissue, 2 for each of the 3 muscles, have a relationship of how they encircle the rectus abdominis muscle in the front, so that the way those connective tissue linings fuse forms the rectus sheath. It's a connective tissue compartmentalization in which the rectus abdominis muscle is setting. Okay? And it's also, when we look at it posteriorly, the formation of the thoracolumbar fascia that encased the intrinsic muscles of the back. In other words, thoracolumbar fascia was lying over the top of the erector spinae muscles, and it lay underneath the erector spinae muscles and multifidus to separate it from quadratus lumborum. So the thoracolumbar fascia, or thoracodorsal fascia, is the posterior fusion of these 6 epimysial layers, and the anterior fusion of those is the rectus sheath. Okay? So when we look at this, on this side, here we have our external obliques. Here we see the connective tissue. In this instance, it's kind of implying that it's just the external oblique fibers, but again, it's 6 layers of connective tissue that are ultimately fusing in a way that then they encapsulate the rectus abdominis muscle, or this muscle that's extending in this vertical fashion. Okay? This side, the rectus sheath, has been reflected. And underneath that you can see rectus abdominis, and it's not one long continuous muscle, but embedded or crossing it, there are these tendinous bands that are anchoring it to the rectus sheath. So in other words, if this muscle's contracting, it contracts from here to here, from here to here, here to here, and here to here, as opposed to one long contraction from the inferior part of the rib cage all the way down to the pubic tubercle. Okay? And the benefit of that is it gives people 6-packs. Okay? That's the benefit. There's no other reason. No. It really makes it for a much more efficient contraction of a muscle. Because if it were just a loose muscle that were spanned from the ribs down to the pubic tubercle, the ability for it to not be displaced in terms of that movement would be pretty easy. I mean, it wouldn't be efficient. But if we shorten it and anchor it to that connective tissue compartmentalization, then each one of these becomes its own small contractile unit, which makes it much more efficient to contract across the entire way. Okay? Now, the external part of the external oblique, as it comes down, is also a part of a rolling, so there's kind of a wrapping of this, that then is what ultimately forms our inguinal ligament. So here's ASIS up here, pubic tubercle down here, and so this is our inguinal ligament that's running along here. And because it's wrapped, it leaves this inguinal canal inside of it, which for the males allows for the spermatic cord to go through there. In women, the analog of that is the round ligament, and it actually goes through there as well, but forms more of an anchor for the ligamentous support for the uterus than anything else. Okay? But it ultimately is this canal. Now, when we look at these 3 muscles, the anterolateral muscles, what you need to look at, and these are really, in my mind, are mislabeled a bit, okay? So if we think about these, layer 1 is the external oblique muscle, okay? And it kind of has this posterior, superior to anterior, inferior orientation of fibers, okay? So they're running from posterior, superior, off the ribs, and wrapping around the wall to inferior, anterior. Okay? Now, in most instances, kind of the simple way to understand internal oblique muscles is that they run in the opposite direction. Okay? In other words, they're running from, and again, these two are mixed. They're wrong. Okay? Just so you know, these are wrong. Okay? When you look at the internal obliques, they're running almost 90 degrees in perpendicular to the external oblique muscles. Okay? So they're running posterior inferior to superior anterior. Okay? That's the general way to view it. And then transverse abdominis is just running around in this leg. These two things should be, D and E should be switched. Okay? Now, that's great. That's the general consensus of this. But the reality of the internal obliques, so not TA but IO, is that they really are this superior anterior orientation is really only seen with the uppermost fibers. As we go more inferiorly, they almost get to the point where they're paralleling the external obliques. Okay? Now, if we go back to this front picture, this frontal view, and say, if we have 6 layers of connective tissue here that are interdigitating and coming together as this rectus sheath, wrapping around rectus abdominis, then they are interlacing along this midline of collagen fibers crossing each other and anchoring each other. And that's linea alba. Okay? When you look at the attachments of all these muscles, they are coming off of some sort of bony landmark, but they are inserting on linea alba, which is just connective tissue. So if you think about the fact that my right external oblique fibers are starting back in my back on bone, on ribs, on transverse processes, and they're sweeping anteriorly, and now they end in connective tissue. If they were to contract, what are they going to do? So contract from here to here, shorten. What are they going to do? Remember, this is connective tissue. It's just going to pull connective tissue this way. Now, that doesn't, so when we talk about rotation of the trunk, that, to make that something a bit more functional, if that interdigitation is coming here and interdigitating with collagen fibers for a muscle that continues in this orientation to this side, which would be the internal oblique fibers, they're now attached down here on the iliac crest. So now we've got bone to connective tissue to bone again, and now when we contract, we're having that muscle contract across a bunch of joints as opposed to just pulling connective tissue. So when we look at rotational pieces, how we rotate the trunk, especially at through the lumbar region, or the lower thoracic, so T11, T12, and then 5 lumbar vertebrae, that rotation can now occur because it's a combination of actions of external oblique kind of interdigitating with internal oblique that's coming all the way to the pelvis. Okay? So when we look at that and we contract the left internal oblique and right external oblique together, and the pelvis is fixed, we're rotating the trunk towards the side of the internal oblique. In other words, we're moving rotation opposite of the external fibers, ipsilateral or toward the side of the internal fibers. And they work together. Okay? Does that make sense? So if I then ask you, how does transversospinalis muscles fit into that picture? Because what do they do? Which way do they rotate the body? To the same side or the opposite side?
Opposite.
Or the opposite side?
Opposite.
So remember, You're taking a spinous process, you've got a transverse process and a spinous process. As that muscle contracts, it pulls this spinous process this direction, which means the front of the body up here is going to go that direction. So transversospinalis muscles rotate the body to the opposite side. External oblique is rotating it to the opposite side, and internal oblique to the same side. So now you have three muscles, three sets of different muscles working around the spine from posterior to anterior to assist in rotation to one side. So if we're going to the left, if we're going to rotate to the left, we have right transversospinalis muscles, right external oblique, and left internal oblique. And we're turning to the left. Okay, so it's a whole, it's not any one of those muscles that does that. It's a combination of all of those muscles that give us that rotational movement. Okay? But again, the only way that would work is if the fact that these connected, 6 layers of connective tissue are specific for that interdigitation working across the midline. Okay? Now, again, here's kind of a different picture. Here's transverse abdominis, and between transverse abdominis and the internal oblique, or within the rectus sheath, is where we see a great deal of the vascular supply and the muscular innervation to those. External to all of that, we have a series of segmental nerves that are the cutaneous nerves specific for sensation to the skin. Okay? The one I wanted to point out specifically is this ilioinguinal nerve right here. This ilioinguinal nerve, which provides sensation to kind of the medial part of the thigh as well as the lateral part of the genital region, is a nerve that runs through the inguinal canal. So consider hernia surgery where that nerve might be compromised, scarred down because of how they sew it to the inguinal rings together, ultimately may affect sensation on the medial side of the thigh, lateral side of the genital region. Okay? That one nerve. All the others are within the cutaneous, within the skin, and stay very segmental, just like we talked about the dorsal rami being segmental to the skin of the back. Okay? I don't want that. I think I'm going to stop there because ultimately now we're getting into the gut. And so I'll start here on Thursday. We'll talk about the compartmentalization of the gut. And I'm going to really simplify this because there's a lot of terminology in terms of pockets and pouches and things like that in the abdomen that I think probably mean absolutely nothing to any of us, other than me, just because it's a question for a test. But beyond that, it really means nothing. For a gastroenterologist or gastrosurgeon, it means a whole lot. But for us, it probably means very little. So I'm going to simplify that and put it into the perspective of the organs that we're going to see. Okay? Any questions? Yes?
When are you posting that extra credit?
I have to get to that because since I didn't have access to the,
Oh, that's fine. I'm just,
but
okay.
today, tomorrow, I'll email you guys.
Okay.
Okay?
Thank you.
So, anything else? No? Okay. See ya.